Welcome to the first International Oral Pathology Conference, hosted by the Scientific Academy of Dental Students and the Diploma in Oral Medicine of the Faculty of Dentistry at Universidad de los Andes. My name is Isidora Mujica. I'm the program director, and I will be hosting the meeting this evening. In an effort to bring the oral pathology community together and to share our interest in continuing education, we welcome you to the first version of this event. It is now my great pleasure to introduce Dr. Annie McLean, our plenary speaker. Born and raised in Portland, Oregon, Annie McLean earned her DMD degree at Oregon Health Sciences University School of Dentistry in 2011. She practiced public health dentistry for 5 years in New Mexico and then moved to Dallas for her oral pathology residency at Texas A&M University College of Dentistry. She graduated in 2019 and earned her initial certification by the American Board of Oral and Maxillofacial Pathology. Dr. McLean enjoyed a year as Dr. Justin Bishop's research assistant at the University of Texas Southwestern Medical Center, while concurrently finishing her master's in science degree at Texas A&M. She recently began the instructorship program in head and neck endocrine pathology at Emory University Hospital in Atlanta. Some of you may also know her from Twitter, where she actively shares interesting cases and diagnoses. Today, she will be presenting 6 cases in total. We will have a brief 2-minute discussion after each case, where you can ask your questions in the chat. We will also have 15 minutes at the end for further questions. And I like to ask you to please keep your microphones muted, but please feel free to ask all your questions in the chat. We are greatly honored to have Dr. McLean to present for this conference. Please join me in welcoming Dr. Annie McLean, and let's give her a warm virtual applause. Dr. McLean, the stage is all yours. Please share your screen and we can start at your convenience.
Muchísimas gracias, Isidora. Es mi placer estar aquí con todos ustedes hablando en mi sujeto favorito, patología oral. Y mucho gusto a todos. Si tienen preguntas de mí, entonces, por favor, que los escriben en el chat y Isidora me va a ayudar con leer estas preguntas a mí después de cada caso. Y otra vez, es mi placer estar aquí con ustedes. Hello, everybody. I'm Dr. Annie McLean. Call me Annie. It is my pleasure to present a CPC or clinico-pathologic conference today in oral pathology. We will be reviewing 6 interesting cases and really emphasizing differential diagnosis. This talk is really geared toward dental students and oral pathology residents. So for those who are more senior that have kindly joined the talk, I hope that you find this interesting and that you enjoy it. Can everybody see my screen?
Yes, it's all working okay.
Perfect. All right, let's get started. All right. Isidora, I keep getting these notifications, just FYI. No worries.
Yeah, don't worry.
Okay, so today what is on the menu? I've already kind of reviewed this with everybody. We're going to give you a little bit of clinical history at the beginning and of course some photos and radiographs. And I will go over with you what I notice in terms of the key features or characteristics of each lesion, and then we will discuss a differential diagnosis. In most cases, I have the histopathology present and occasionally some IHC, and then we will review the diagnosis and some quick facts about that diagnosis. Again, this is not meant to be an exhaustive list of everything possible that this could be, but this is meant to be really fun. So let's go for it. wanted to talk about my approach. I think that the hallmark of a truly good doctor, a truly good oral pathologist, is that you always analyze your approach and you are willing to accept new ideas and to evolve. So my approach is always under construction. When I was a brand new first-year resident, I always felt so excited and honestly a little bit terrified whenever I saw patients, especially live, that had oral lesions, and it was my job to be the detective and figure it out. Still is my job. So I am doing my best to move from excited and terrified to a calm and cool cucumber, which is an American phrase. Hopefully everybody is familiar with that. So the more calm and collected we can be during a differential, the more systematic and logical we can be as well, which really will benefit our patients in the long run. Differential diagnosis is truly an art and a science. Again, as I referred to earlier, my biggest problem was to remember to remain calm and breathe. And I've gotten a little bit better at that as I have evolved as an oral pathologist. Make sure to always take your time when developing a differential diagnosis. Really take your time to notice any key features of your case and always dig into the patient's medical history. Whenever you find that you are stumped, that you are stuck, make sure to give yourself some time away and then take a second look at the case. You'd be surprised what you could think of when you have a fresh brain. Always, again, be systematic and logical, and I find it very helpful to rank order your differentials. That means to list them in terms of most likely to least likely. It helps to organize one's thoughts. This is a structure that many students start to use in terms of trying to think systematically. These are the classic Neville and Dam chapters, and they really forced me when I was beginning to consider every category of disease that we could think of. So I still kind of have these chapters in the back of my head. It's rather maybe sad, maybe strange that I was able to list all of these chapters out by memory, but that's what studying for the American Board of Oral Pathology does to you. Now we will begin with our cases. Case 1 is the case of a 40-year-old female with a history of HIV who presents with multifocal and painful oral lesions. I will now show you her clinical presentation. So we have these yellow, flat lesions that are surrounded by an erythematous halo or an erythematous rim. And you can see that some of them are quite punctate and small, and maybe some are gathering together to form these larger areas. She also has lesions present on her tongue on the left side. And these look very similar to the lesions present on her buccal mucosa. She has lesions present on her, notice maybe a little bit onto her hard palate here, and then onto retromolar trigone, gingiva, and her posterior soft palate. So it's very important to note the distribution of these lesions. She also has lesions present on her labial mucosa, and perhaps we can appreciate that this is a little bit raised, but again, these lesions are small and they are coalescing together to form larger areas. So now we have a differential diagnosis that we will present. The two main categories of disease that I have in my mind are inflammatory or reactive and neoplastic in nature. Now, these lesions began maybe a few days ago, let's say, and really a neoplastic process, unless it's very, very severe, will be more slow growing than just coming on during a few days. So I do favor, because of that reason, this process being more inflammatory in nature. Now, I went through my chapters in my head and I came up with a couple of different ideas for this case. The first is I would think about an infectious organism here. Classically, Streptococcus and Staphylococcus bacteria cause pharyngitis, but it would be a little bit different to have true oral manifestations as opposed to only isolated to the oral pharynx. A fungal infection may cause some yellowish plaques on the in the areas that are affected anatomically. However, the distribution of this is pretty widespread. Now, remember, I told you that the patient has a history of HIV. So theoretically, this patient is immunocompromised unless, well, pretty much they're immunocompromised, even if their disease is well controlled and their viral load is small. So candidiasis is still a possibility here, in my opinion. I highlighted viral in purple because viral infections are known to affect patients that are immunocompromised. So herpes simplex virus and cytomegalovirus really jump up high in my differential diagnosis here. Considering that I'm interpreting these lesions as ulcers, we do need to consider some other processes that may be immune mediated in nature. Behçet disease, which is a rare-ish autoimmune condition that affects the oral mucosa in terms of aphthous ulcers, may be considered in this situation, as could a drug reaction. And again, we're thinking, she's immunocompromised, so this person is very susceptible to infection. All right, now we move to the histopathology. This is a low power image here showing an intraepithelial vesicle that is filled with a bit of fluid. You can see that we have a few cells that are floating in this. This is a lower power view present with some very altered epithelial cells and some fluid or edema or possibly ulceration present surrounding those cells. You can see that the epithelium is markedly abnormal. And so some sort of process must be occurring. You can also see some acute inflammation down in the lamina propria. Here's a higher power view. Oh, I apologize. Here's a higher power view of what may be going on with those epithelial cells. We really have some significant alterations present. You can see that this is one cell right here, and you can see that we have these very large inclusions within the cell. We also have some dyskeratosis or some altered cytoplasm in the cells. There is some optical clearing of the nucleoli, or pardon me, the nuclei here, and some possible margination of the chromatin around this. So we do call this ballooning degeneration, and this is a hallmark of this disease process. Here is a cytologic smear taken from the cells of one of these vesicles that has burst and become an ulcer. Again, we can see very large nuclei that are virally altered. There's a hint. And they exhibit these Cowdery type A inclusions, and these are known as Zank cells. That's TZANCK. This is an immunohistochemical stain for HSV1, and we can see that it is positive in those bizarre altered keratinocytes. So our diagnosis here is herpes simplex 1 infection. Most oral cases of this disease, of herpes actually, are caused by HSV1, about 90%. Now there is an HSV2, but that virus preferentially infects the genital mucosa. Herpes is a double-stranded DNA virus of which there are many different variants. And this virus remains latent in our sensory ganglia after initial infection. And many people are actually asymptomatic when they contract herpes. This is an exceedingly common virus to have. And unfortunately, once you get it in your system, we don't have a way of getting rid of it yet. Primary herpes typically occurs in children, and most often it's asymptomatic. However, herpes may very ragingly affect the oral cavity in the form of acute herpetic gingivostomatitis, in which it may be found on the labial mucosa, the buccal mucosa, the soft palate, the gingiva, and the tongue, and even the floor of mouth. This is an exceedingly difficult condition to deal with, especially if you have this in maybe your son or daughter that's very little, because these lesions are quite painful. Recurrent herpes typically presents as herpes labialis, which is also known as cold sores, at least here in the States. And intraorally recurrent herpes typically occurs on bound down mucosa. So that would be the mucosa of the gingiva and the hard palate. However, immunocompromised patients, when they have recurrent herpes, may show widespread distribution of lesions in the oral cavity, almost more in the pattern of an acute herpetic gingivostomatitis. Again, the histology exhibits ballooning degeneration of keratinocytes and Zank cells, and those the ballooning degeneration is falls within the category of what we call viral cytopathic effect. Very good. I would like to invite anybody to ask questions at this time regarding my first case.
We don't seem to have any questions right now, Andy, so
Okay.
maybe we can move on.
Yes, ma'am, that sounds great.
Has any questions later.
Sure, sounds good.
Okay.
All right, case 2. We have an 18-year-old white male with long-standing bilateral white lesions of the tongue and the buccal mucosa. Let's see his pictures. So this is quite interesting. First, we can notice a bit of fluorosis on his teeth and maybe some gingivitis, so perhaps his dental care isn't the best. The most impressive finding here is these widespread white spongy plaques that are present on his buccal mucosa. And let's check out if there's any further distribution hints that we may have. Here's the other side, and this looks even better in terms of what this disease process is. We have kind of corrugated, shaggy white plaques that are present. Not all of the buccal mucosa is affected in a uniform way. Oh, goodness. Yes, there we go. I will let you know that the patient also had some lesions on the side of his tongue that looked identical to the lesions on the buccal mucosa. So let's go through a differential diagnosis for this. We have some interesting things to consider here. One of the conditions that can cause a white appearance of the buccal mucosa is a condition called leukoedema. However, that typically goes away when the tissue is stretched. And this condition does not go away. What the patient has does not go away when the tissue is stretched. In terms of infectious disease, chronic hyperplastic candidiasis is a definite consideration. However, we're given the information that these lesions are long-standing. So granted, chronic hyperplastic candidiasis is a chronic condition in itself, but I will tell you, these lesions have been present since childhood in this patient. So that's still a decent consideration, but I would consider something dermatologic, honestly. We have some genokeratoses that are definitely within our differential diagnosis, including hereditary benign intraepithelial disc keratosis, white sponge nevus, and the two much more rare conditions, Pachyonychia congenita and disc keratosis congenita. I've highlighted white sponge nevus and hereditary benign intraepithelial disc keratosis because they do occur more commonly, and these are things that typically affect patients from birth. These are genetic conditions, and so we really would consider that more often. So let's proceed to the histologic images. We have, as we can notice, some spongy type edema in the spinous layer of the epithelium here, and it does progress down a little bit further here. We have some hyperkeratosis, so this is very hyperplastic epithelium present. And at a higher power view, we notice these small condensed nuclei that have perinuclear eosinophilic condensation around them. And there is some spongiosis or some intracellular edema present as well, kind of spread throughout, distributed throughout the spinous layer of the epithelium. So here is a smear, a cytologic preparation of the pathologic process that's occurring, and we can observe that perinuclear condensation of eosinophilic material even better on this smear. Shout out to cytology. Okay, so our diagnosis is white sponge nevus. This is a genokeratosis. It is a genetic defect in the normal keratinization of oral mucosa, for which keratin 4 and keratin 13 genes are absolutely essential. These genes are expressed in the spinous layer of oral epithelium, which is exactly where we found our pathologic alterations within the epithelium. Now, white sponge nevus typically presents at birth or in early childhood, and this may be present in the child's parents as well. This is a genetic condition after all. The typical clinical presentation is bilaterally symmetric, thickened white plaques that are present. They can be present all over the oral cavity soft tissues, soft palate, tongue, floor of mouth, and buccal mucosa and labial mucosa are the most common sites. Histologically, as we mentioned, there is hyperkeratosis, intracellular edema, acanthosis or thickening of the epithelium, and classically perinuclear eosinophilic condensation of the cytoplasm. Since this is a benign condition, no treatment is typically necessary, and these patients do very well. Okay, little pause for any questions here as well. Can't quite hear, so I will go ahead and continue if that's okay.
Annie, we have two questions.
Yes, please.
So Maria Jose Garib asks, assuming that the patient considers them annoying or not aesthetic at all, would you suggest any treatment in surgical terms?
Oh my, that is a very interesting question. I'm sure that some patients are concerned regarding the aesthetics of this condition. I feel rather uncomfortable as a pathologist recommending specific treatment for this. The one thing that jumped to my mind is perhaps some sort of chemical cautery or some sort of laser treatment may help in reducing the hyperkeratosis of the lesions. However, I'm a little uncomfortable speculating on that. If I ever meet a surgeon that has treated this condition, I will give you guys a call and let you know. Thank you for the question.
Well, and Dr. Krishna Risha asked if we can add PLD in differentials.
That is an excellent question, and I would definitely add PBL in my differential. So I didn't have it written on my differential diagnosis. I think it definitely belongs there. That's an oversight on my part. However, I will make a comment. The incredible involvement of the percentage of mucosa that is involved in the case that I showed. Honestly, I would expect something to have turned to cancer already if this was truly a setting of proliferative leukoplakia. Sorry, can that person go ahead and mute, possibly? Thank you. So I would have expected, honestly, some aspect of that lesion, if it was truly PVL, to have turned to cancer at this point, considering that over 60% of patients with PVL will eventually show invasive squamous cell carcinoma present. So you're absolutely right. PVL belongs in the differential, but I'm hoping that this patient will do just fine and that this is a benign condition. Thank you.
Okay, thank you very much. I think we can move on to the next case, and we'll save some questions for the end.
Sure.
Thank you.
All right, here's case number 3. We have a 30-year-old male with an ulcer of the lateral tongue, and this has been present for several months. Looks kind of scary. I'm hoping that everybody is a bit scared right now. This is a large, indurated, centrally ulcerated lesion that is exophytic in nature. You can see that it's truly coming off of the normal plane of the tongue. We have the normal tongue here, and then this is just a very large, angry-looking lesion present. You can see the probe is about 1 centimeter in length, and this is well over a centimeter in terms of the superior-inferior dimension, and definitely maybe even 2 or 3 centimeters in terms of the anterior-posterior orientation. So right away, looking at this picture, I'm pretty concerned. Here's another image. You can see that we have some vascularity present here. The lesion is kind of red-purple with some whitish areas. And again, pretty concerning. So let's go to a differential here. In terms of differential, we do need to consider squamous cell carcinoma at the very top of our list. For me, this is squamous cell carcinoma until biopsied and proven otherwise. Other considerations include infectious processes. A fungal infection would be high on my differential as well. Fungal infections do occur, definitely, and it doesn't always have to do with patients that have been traveling to tropical areas recently. Actually, several species of fungus are endemic to the United States, for example. Syphilis is also a consideration here. That's a very, very interesting disease process, and tuberculosis as well, inducing some sort of granulomatous inflammation is a consideration. Of course, clinically, we would want to rule out any sort of physical or chemical injury because a TUGSI, or a traumatic ulcerative granuloma with stromal eosinophilia, is definitely high on my differential here as well. In terms of neoplastic considerations, it is possible that other malignancies may present as an ulcerative indurated lesion on the tongue. However, they would be exceedingly rare compared to the other entities that we have present on our differential. Now let's go to the histology. You can see that we have some parakeratosis present and possibly a little bit of epithelial hyperplasia. There's plenty of intraepithelial inflammatory cells that are present. Looks like most of them are lymphocytes. We have a mitotic figure here, but it's located at the basal layer, so I'm just fine with that. In the lamina propria, you can see we have some very superficial inflammation. And maybe if you scoot back quite a bit, you could imagine that this is creating a little bit of a ball. So my brain is tickled at perhaps the thought of a granulomatous process here. And the inflammation does seem to be mixed. There is some evidence of plasma cells present and also lymphocytes. Here's a bit of a higher power view. And you can see this is a lot more plasmacytic in this area. And you know, something I would do if I were to get a case like this might be a CD68, which is a histiocytic marker. I'd really like to see if there are any histiocytes because those are a key cell in the presence of granulomatous inflammation. Okay, what do you think? This is the part when I would love to interact with the audience, but I know that there are so many of us, and thank you very much for attending. So I will describe what I see. This is an immunohistochemical stain for Treponema pallidum. You can see that we have these tiny little guys. Actually, if we were to look at even higher power, they would exhibit a corkscrew morphology. And so these are spirochetes. These are bacteria. And of course, Treponema pallidum is the causative organism of syphilis. So syphilis is a sexually transmitted bacterial infection. Unfortunately, its prevalence, is increasing in the United States and around the world. This is a global problem. This disease is very complex with many different systemic manifestations and local manifestations. Primary syphilis, at least orally and genitally, presents as a chancre or a kind of rolled indurated ulcerative lesion, very similar to what we saw in the oral cavity in this young man. Most cases present in the genital region. Only about 4% of cases present orally. And if the patient is left untreated for many weeks, they may progress into secondary syphilis, which is the second stage of the disease. This is marked by your typical systemic symptoms, and like they mimic something like a tonsillitis or pharyngitis. You can have non-tender lymphadenopathy, a fever, a sore throat, a headache, weight loss, etc. So these are fairly non-specific in nature. The lesions typically seen on the oral mucosa and genital mucosa may involve mucus patches, which look like white, slightly raised, flat lesions, split papules, which you can typically see at the corner of the mouth, and condyloma lata, which may present as broad-based bumps. Again, if the patient is left untreated, and this may present many years after the patient's initial infection, the patient may progress to tertiary syphilis. This presents as a gumma with granulomatous inflammation, and this actually is what was demonstrated histologically in our case. So this guy had probably had syphilis for quite a while. You can also see glossitis or luetic glossitis, so that would be inflammation of the tongue. To me, the aspect of tertiary syphilis that most catches my imagination is the central nervous system involvement, which may present as dementia or psychosis. I also want to give an honorable nod to congenital syphilis here. Syphilis does pass through the placenta from mother to fetus. And I'll only mention the oral manifestations here because congenital syphilis is basically a topic in itself. Hutchinson incisors or notched incisors and mulberry or berry-shaped molars may be present in congenital syphilis. This disease is easily cured by a shot of penicillin, so hopefully we can decrease its prevalence once again. Any questions here?
Yes, Annie, thank you. We have some questions. Dr. Benjamin Martinez would like to know if the patient is HIV positive.
That's a very good question. We were not given that information at the start. However, once we diagnosed the syphilis and asked the clinician, the patient was immunocompromised. They had been treated for a previous lymphoma.
Okay, thank you. And Dr. Krishna Sirisha wants to know if the immunohistochemistry is unavailable, then how do we proceed for diagnosis?
If it is not available?
Yes.
Oh, goodness. That is pretty complex. I would say if the patient exhibits any other lesions or symptoms, refer the patient to their primary physician, and hopefully that person would be able to further help the patient. I'm not aware of serology testing, blood testing that would exhibit any signs of syphilis. This is a complex question. So I will say that I don't 100% know, and I would actually love to research it and get back to you. I appreciate it. Maybe we can both look into it.
Well, thank you. And last question regarding this case. What's your take on malignization of the secondary stage of syphilis, of the ulcers?
Of manifestation?
Yes.
Okay, very good. Gosh, secondary syphilis tends to be the most tricky to look at, and therefore I would always recommend at least an incisional biopsy if you were to see a lesion that resembles any one of these mucus patch, split papule, or condyloma lata. The only case that I've ever actually seen a biopsy of was a biopsy of a broad-based bump on the dorsal surface of the tongue, which was identified as a condyloma lata. So this is a little bit challenging in terms of my lack of clinical experience, and I'd love to ask an infectious disease doctor what they would think of this, but kind of tough to do. Syphilis is so nonspecific. That's why it's really known as, well, syphilis and melanoma are the great mimickers in pathology, or at least that's their reputation. So I would always say biopsy if in doubt.
Well, thank you.
Thank you very much. Moving on. Okay, case number 4, we have a 60-year-old woman who presents with a chief concern of tightness of the skin of her face, some cold hands and feet, and this interesting radiographic appearance. So aside from her nose ring, aside from her bad teeth that we have, and her root tips, we have some alterations present in the mandible that are rather interesting. We have these notches of the posterior aspect of the ramus here, and notice that they are bilateral and they seem relatively symmetric. Panoramic radiograph evaluation is not the best to interpret this next feature that I would like to point out in this case. Perhaps you can appreciate a little bit of some symmetrical widening of the PDL space here. There's quite a bit of space between this tooth and the adjacent crestal bone. You can also see that here. Now, granted, this tooth is periodontally involved, so maybe we're seeing something a little bit different, but we can maybe appreciate symmetrical widening of the PDL. So this one is honestly a really difficult case. What could cause bilaterally symmetric erosion of the mandible? I was racking my brain for this, and maybe some osteoporosis in an odd pattern, maybe some sort of other inflammatory process. I know of nothing neoplastic that would do this in particular without some sort of other manifestation in the bone as well. So I'm just going to say, I thought about it a lot, and I was wondering if my audience would come up with any further good ideas for this. However, sometimes you just got to see one example and you'll remember it forever. The diagnosis here is actually systemic sclerosis, also known as scleroderma. Now, sclero means hard and derma means skin. So remember that our patient had a manifestation of very tight facial skin, and that is something that we do see with patients with scleroderma. This is a pretty rare condition, and most likely it is immune mediated in some way. Scleroderma is characterized by increased increased collagen deposition underneath the skin, which is the reason that the skin becomes rather fibrotic, stretched, and hard. Scleroderma can really affect any body tissue. It can affect the vascularity. It does affect connective tissue almost by definition, and it can affect your immune cells as well. If multiple organs are involved, this condition may be life-threatening because it may place the patient in organ failure. For example, the heart can be affected in cases of scleroderma, and if the heart is compromised, then the body's circulatory system is compromised. So there is the potential for ischemia and infarction. Usually, scleroderma manifests at the very beginning as Raynaud phenomenon, which is cold hands and feet. Eventually, you can see further alterations in especially the hands, because the skin gets so tight that the fingers begin to crinkle and curl. And this is known as a claw-like deformity. Those are the buzzwords for this condition. Oral manifestations, and I actually had a patient with scleroderma in in public health. She had very significant microsomia. I have pretty long and thin fingers, and so I thought I was a decent dentist. It was pretty fun, but I had a real challenging time trying to do any dental work in my patient's mouth who has scleroderma. It was hard. There's also, as we mentioned, diffuse widening of the PDL space and resorption of various aspects of the mandible due to actually muscles and tendons pulling on the mandible over time. Oh, I apologize. Any questions about this?
I'm not seeing any questions right now regarding this case. If anyone has any questions, please, you can ask your question in the chat box.
Thank you very much. All right, on to case number 5. And I will say that this is my favorite case that I have included today. This case was actually featured on CNN, which is a United States news network, and I think a rather trustworthy one. And this was a story that was run in 2017. My mentor, Dr. John Wright at Texas A&M, has a good friend who is a prominent oral surgeon in Louisiana, and his name is Dr. Ghali. And Dr. Ghali reaches out and does pro bono surgeries on occasion for people that otherwise would not be able to afford this kind of care. I would like to present the case of a 3-year-old, otherwise healthy Brazilian girl with a large jaw tumor. Here she is. You can tell she perhaps is a bit distressed in this picture. She has a very, very large tumor that almost is the size of another one of her head, almost the size of a head that's attached to her lower jaw here. You can see already that it is rather multilobular in appearance here. And you can see that we have a large area of skin ulceration and crust that has developed. Now, I believe this tumor had been present for a year or two, and it had been slowly growing over time. So that's something to note. So just looking at this picture, can we tell whether this is benign or malignant? For me, not quite. I would associate slow growing with a typical benign process. However, the skin ulceration and the size of the lesion is quite impressive. We know that can happen with benign lesions, but also on occasion with malignant ones. Here she is again, hugging her little puppy. I just think she's the cutest thing. And I do apologize, we didn't have any radiographs on this little girl's case, honestly, because she may not have fit her head into the panoramic or CT machine. So this is a substitute radiograph courtesy of Dr. Aziz Benacer from his lovely publication on this particular entity. You can see that we have a multilocular radiolucency present in the left mandible. You can see that we have some septae of bone that are still present between some of the locules. And there is some bony expansion that we can appreciate perhaps right here, extracortical. This process has also shoved a tooth way up next to the coronoid process. So right now, clinically, can we say whether this is benign or malignant? I always ask myself that question. And to be honest, this is looking up more benign to me. It is kind of respecting the borders of the bone, and it seems to me to be gently pushing. It is also resorbing a little bit of some tooth root here, but considering these roots are perhaps still intact, that's a feature that can happen with benign lesions. This sort of soap bubble appearance is classic for a few odontogenic lesions or lesions that come from odontogenic epithelium, which are definitely on our differential diagnosis. So here is our differential. First off, we want to consider the horses because they're much more common. So the horses for me in this case are the entities that are highlighted in lavender here. I would consider odontogenic lesions first and foremost. Odontogenic keratosis is something that can easily present as a multilocular radiolucency. So can ameloblastoma. This is a particularly locally aggressive tumor, as is odontogenic myxoma. And, you know, malignancy, I don't necessarily favor it at this point, but we do need to keep it in the back of our minds. Another thing to consider here, especially considering the little girl's age, she would still be on the young side for almost any of these tumors. Central giant cell granuloma is a bone tumor that can be seen in children and adolescents, and it can present as a multilocular radiolucency, just as we saw on the substitute radiograph. This isn't quite the distribution that is typical of cherubism, which is a benign fibroosseous condition that causes swelling of the jaw. It can very rarely be unilateral, but really cherubism does not cause this extent of a tumor. The tumor is too big, in my mind, to be cherubism. We can also consider vascular abnormalities that can create soap bubble type radiolucencies in the jaw, as well as intraosseous mucoepidermoid carcinoma, which I think would be a true unicorn. Here is a histologic image of the girl's biopsy. You can see that we have some really delicate, beautiful spindle-shaped cells that are suspended in a rather myxoid type matrix. And it turns out that this material is mostly hyaluronic acid. You can see that there is some decent vascularity in here, and that overall our cellularity is not super high. I would say this is moderate to slightly less cellular than your typical neoplasm would be. You can notice that there's not a lot of nuclear atypia or cytologic atypia, and I did not appreciate any mitotic figures. We also have a sprinkling of lymphocytes. The diagnosis in this case, fortunately for this little girl, is a benign odontogenic tumor called myxoma. This is the third most common odontogenic tumor after odontoma and, ameloblastoma. Now, some people might take me to court over claiming that this is the third most common odontogenic tumor because because odontoma may be considered a hamartomatous process. So depends on whether you count that as a tumor. Typical age range for odontogenic myxoma is in your second to fourth decades, and most of them are located in the posterior mandibular region. When these lesions are located in the maxilla, they can actually be quite destructive. They can be pretty locally aggressive because the bone is much more porous and easy for the lesion to blow through. Radiographically, as we mentioned previously, there is a soap bubble appearance resulting in a well-defined uni or multilocular radiolucency. Grossly, this looks rather translucent. It may be firm, it may be gelatinous, but usually there is a translucent mucinous appearance to this tumor. And as we mentioned, the histopathologic features include stellate spindled cells in a variably mucoid to fibrous background with little atypia. And I have seen a case that contained significant calcification or bone. I will tell you that frequently in myxomas, you can actually see a lot of reactive bone at the periphery because this tumor is fairly infiltrative, even though it's benign. So treatment is typically resection with significant uninvolved margins. Usually this tumor has progressed further than what we are able to determine radiographically. So resections need to be done with care. The prognosis is pretty good. However, we need to note that the recurrence rate is about 25%. So I think that these patients need to be monitored long-term. This little girl had her treatment. She went through recovery, and just look how beautiful she is. I'm just so thrilled. It makes my heart happy to see this little girl with her face more manageable and disease-free. Do we have any questions about this case?
Yes, we have two questions. Alejandro Tapia would like to know, why did you not consider true giant cell tumor?
That is a very interesting question. To be honest, I have never seen an example of true giant cell tumor of bone. I more associate those to be in the long bones of teenagers. So this can be a little bit challenging and controversial. As soon as I see an example, I would like to really study the histologic features and determine whether there really is a difference for me between central giant cell granuloma and giant cell tumor of bone. So that's a great question, but really the location was what swayed me in this instance.
Okay, thank you. And we have a couple more questions. Carolina Martinez would like to know, what caused the skin to ulcer, the ulceration?
I understand. I'm guessing, I'm thinking that the lesion was growing to the extent that perhaps her skin remodeling may not have been able to keep up, and there was some sort of perforation of the jaw and of the skin itself. So that's kind of tough to speculate on, but that's what I would imagine happened.
Okay, thank you. And Dr. Benjamin Martinez would like to know, why did you not consider myofibroma? And what about the immunohistochemistry results?
Understand.
Did you do SMA, S100, etc.?
I see. We did an S100 and it was negative in this case. And so that's actually, goodness, see, I forget things on my differential too. I am always a work in progress. I would consider a myxoid neurofibroma here. However, I have never seen or heard of one getting so large. Myofibroma, I think, is a very reasonable thought. They can definitely have interosseous involvement. So this is challenging. However, a soap bubble typical radiographic appearance, I'm not really aware of. Myofibroma can look a little bit more destructive in terms of the examples that I've seen in the past, blowing through bone and not maintaining a corticated border of the lesion. So those are my thoughts regarding myofibroma. I think it's still reasonable, but this just kind of struck me as going in a different direction. Immunohistochemically, these are, I grew up, quote unquote, in a program that did not actually do a lot of immunohistochemistry. I believe that, an S100 was done in this case and it was negative, and that was enough for my faculty to go ahead and call it myxoma.
Well, thank you. I think we can move on.
Okay. Last case. Now, if you guys know me, you'll know that I saved a good one for last. This is a 57-year-old, otherwise healthy male with a firm lower lip mass. There was a history of him biting the mass about 5 months previously, but the mass did not heal and it was present before he bit it. The mass is slowly growing in size, and we received both a clinical picture and a biopsy. Here is the picture of his lower lip mass. Now, some things that I noticed right away, it doesn't look to me like this mass is coming from the skin. This to me looks like it is mucosal. And so I would interpret this as being mucosal in nature. You can also see that we really have a welling kind of exophytic lesion that is ulcerated. You can see the surface alteration here as compared to the mucosa. And it makes absolute sense that he would have traumatized this lesion. After all, if you oppose his teeth here and here, that lesion would very much be in the way, I would guess. Key features here in this case is that this lesion has been present for months. There was a history of trauma, but we didn't have any healing. The lesion is continuing to grow. And again, I favor this being mucosal in nature with surface ulceration. It would be worth it to look into the patient's medical history, but what we got from the oral surgeon is that the patient was otherwise healthy with no known medical conditions. My differential diagnosis here would be, I really would think that this would be reactive or inflammatory in nature. This was actually submitted to us with a clinical diagnosis of fibroma with pyogenic granuloma. I thought of an abscess, but I kind of ended up striking that thought or eliminating that thought due to the long-standing nature of this lesion and the fact that the patient didn't have any other systemic symptoms. I think that an ulcerated fibroma is a very reasonable thought and very common, as well as a pyogenic granuloma, another reactive lesion. Could we consider any epithelial tumors here? Could this be squamous cell carcinoma? To me, this looks rather different. It's very exophytic and very, I want to say it looks like a crystal ball. There really doesn't look like a papillary type structure. However, with any ulcerated lesion in the mouth, squamous cell carcinoma, in my opinion, should be considered. Could this be a keratoacanthoma? Now, that's a skin lesion that is very controversial. Many people consider it a well-differentiated squamous cell carcinoma. However, with this being mucosal in my interpretation, I nixed that thought. Is it possible that this could be a different carcinoma or another soft tissue tumor? My goodness, we have many, many soft tissue tumors, depending upon the tissue of origin, leiomyoma, myofibroma, even a lipoma, something like that, although this doesn't look particularly yellow. All of those could be considerations, as well as the malignant counterparts of those. And I put a picture of a volcano because this lesion kind of looks like it is erupting out of this guy's lip. So I have an imagination and it serves me well on occasion in pathology. This is our biopsy. Pretty intense, I think. So we have a beautiful clear cell lesion. So that means that we have abundant clear cytoplasm present in these cells. To me, they don't look exceedingly atypical. And we note the beautiful growth pattern here. This is a nested lobular growth pattern, which is classically known by the German term Zellballen, which means cell balls. Now, once we have a clear cell lesion like this, my differential really narrowed down quite a bit. I thought of things like paraganglioma, and this is absolutely the wrong location for that tumor. Typically, those are seen in the carotid body or even the ear. I thought of some sort of clear cell carcinoma. And could this be a primary lesion? I don't know of much primary to this site that could occur other than perhaps a minor salivary gland clear cell carcinoma, which would be exceedingly rare. Usually clear cell carcinomas of salivary glands arise within the major glands. Then we considered metastatic disease here. Although we're given a history of the patient being relatively healthy and no known medical conditions, this did prompt us to ask the surgeon in terms of, is there any way to investigate this patient's health? This is an immunohistochemical stain for PAX8, and we can see that it is definitely nuclear positive. And this is an immunohistochemical stain for RCC, which is a marker of renal cell carcinoma. Now you can see that it's not very strong, but typically this will stain wispy little cells at the periphery, or rather, membranous staining in some cases. And so this was called positive. The oral surgeon referred the patient to his primary care doctor, who worked up the patient based on our diagnosis of clear cell carcinoma, primary versus metastatic disease. The patient had a kidney mass that was present. The patient had metastatic lesions to the ileum. The patient had metastatic liver deposits. And the patient had innumerable metastases to the lungs. Our diagnosis here is metastatic clear cell renal cell carcinoma. It is important to keep metastatic carcinomas in the back of your mind in terms of doing a differential diagnosis in oral pathology. They do make up 1 to 3% of oral cavity tumors. The most common location for metastatic carcinomas to the jaws or to the oral cavity is the gingiva, followed by the jaws and the oral soft tissues, as in our case. These lesions can mimic reactive processes. They can mimic a pyogenic granuloma like what we saw. They can mimic fibromas on the gingiva. This is pretty scary. So biopsy is always indicated, in my opinion. An interesting fact from this paper by Hirschberg, published in Head and Neck Pathology in 2014, roughly 25% of cases of oral metastases are the first clinical presentation of the patient's disease. And that's exactly what we had in our case. So this really mattered for this patient. And unfortunately, I'm sure that he is not doing well. Hopefully he received very good treatment. This was a case that was diagnosed by our faculty back in 2017. So my fingers are always crossed for these patients, but chances are, because of the widespread nature of his disease in terms of metastases, chances are that he's not doing well. So it's important to always keep metastatic disease in the back of your mind. I'll just go to my last slide here. This is myself and my colleague Dan, and we are being very good in socially distancing and wearing our masks. This is me smiling after signing out my very first case at Emory, which was last week. I signed out a fibroma, and yes, I showed it to multiple people. I want to thank you all very much for having me. Muchísimas gracias por enviarme a hablar con ustedes. And I would like to take any further questions at this time.
Well, thank you very much. It was a great talk, very interesting cases. And I think we have a few more questions. Would you like me to read the questions regarding this case first, and then we can go on to some other questions?
Claro, está bien conmigo.
Okay. So Alejandro Tapia would like to know if the patient did have some symptoms regarding chronic stage renal disease.
None. None.
Okay, so
it was
no signs
astonishing to us. Yeah, very sad.
Well, if anyone has any questions regarding this case, Carolina Hermosilla is asking, have you seen any oral squamous cell carcinoma in the mouth that is HPV positive? If so, where?
One case, floor of mouth, and I do not know what that means. If anybody can help me to eventually answer that question by doing an amazing research study and following patients long-term for 20 years to see how they do, that would be incredible. But we're still just not sure. That's a wonderful question.
Well, thank you. And we have a few more questions regarding the first cases. For instance, Dr. Sergio Gonzalez would like to know, what's your take on asymptomatic 8-SAV viral shedding in the oral cavity?
I understand. When a patient has open lesions like that, HSV is definitely shed in the saliva. And so it would be most appropriate to keep one's saliva to oneself in that instance. I believe after any sores have closed and healed, so that's typically after about 14 days, that the patient no longer is infectious in that way. However, the virus does remain latent in our ganglia, and so further eruption, further cold sores are always possible. So it's something that a patient will have to pay attention to and watch. However, in a way, in dentistry and pathology, pain is a pretty powerful signal to the clinician and to patients. So typically patients will get prodromal type symptoms of itching or tingling of the site, especially in the setting of herpes labialis. And so if they start to have those symptoms, most patients that have multiple recurrences will have some sort of prophylactic or kind of PRN prescription for something like valacyclovir or acyclovir from their physicians. And so they can front load with 2 grams of valacyclovir per day for the first couple days, and then take the duration of the course of the medication and really shorten those symptoms quite a bit, or shorten the duration and lessen the symptoms.
Okay, thank you. Dr. Benjamin Martinez has another question regarding HSV. He would like to know, are there any clinical differences between HSV1 and 2 when presented in the oral mucosa?
I see. I actually think they present pretty similarly. My understanding is this, you can't really tell other than playing the odds. Most cases of herpes simplex infection in the oral cavity are due to HSV1, but I think I've seen one case of herpes that proved to be HSV2 in the oral cavity. And to me, the clinical photo looked very similar. Vesiculo-ulcerative lesions that start as vesicles and rupture and coalesce to create ulcers. So good question. And I don't think there's much of a difference.
Okay, thank you. And well, regarding the scleroderma, Margot Araya would like to know, does it always present bilaterally when found in the mandible?
Every radiograph that I have seen, and that's a total of 3, because this is so rare, has presented bilaterally. Both of the rami and condyles coronoid processes have been affected very similarly on both sides. When I see, or if I ever see a unilateral case, I will be astonished, because this is a systemic disease. So we have every reason to expect that the changes would affect all of the patient bilaterally. But great question.
Okay, and we have another question. Agustin Marquez would like to know, if the renal cell carcinoma histopathology appears in the mandible, what differentials would you consider?
Appears in the mandible?
Yeah.
Okay, here we go.
Yes.
So I would still call it a clear cell carcinoma. There are other possibilities here. There is the possibility of a clear cell odontogenic carcinoma, an exceedingly rare entity, but I guess we would up our differential if that were present in the jaw. We could have some sort of other metastatic clear cell carcinoma, perhaps from a major salivary gland. And both odontogenic clear cell carcinoma and clear cell carcinoma of the salivary glands would be positive for EWSR1. However, to be honest, considering the numbers, my number one choice in that situation would be a clear cell renal cell carcinoma. There are some carcinomas that tend to metastasize more often to the oral cavity, namely the gingiva and the jaws. Kidney is one of them, as are breast, lung, prostate, and thyroid, and female genital tract lesions.
Okay, thank you. And Rene Jara would like to thank you for your talk.
Hi, Rene.
He would like to know, what's your immunohistochemical approach for clear cells? Would you recommend CD10 if we don't have PAX8 available?
Rene, you have hit the nail on the head with that one. So of course I would start with a pan-cytokeratin to make sure that we're dealing with a carcinoma. And then it would really depend on the clinical suspicion. This is horrible. I'm still pretty new at this, guys. So I'm wondering if there's some sort of EWSR1 immunohistochemistry. Perhaps some of you know, and I don't, but I know for sure there's a molecular test to be able to identify that particular alteration. CD10 is not a marker that I'm very familiar with, Rene. So that is a little bit tough. I've had PAX8 available to me, as well as RCC in the past. So this is challenging, and I think I would have to read further. So good question, mi amigo.
Well, thank you. And Doctora Verónica Palacios would like to know how many oral pathologists are trained each year at your university?
At my university, Texas A&M, we accept and train one oral pathology resident per year, and it is a 3-year program here. So we, just one.
Well, and Carolina Hermosilla would like to know, do you think that chronic mucosal trauma can actually cause cancer?
I'm laughing because I just reviewed a paper on oral lichen planus and malignant transformation. So I actually just read into this issue a little bit because I was not particularly convinced. Officially, chronic inflammation is a risk factor in the development of oral cancer, and that has been demonstrated in several different studies that I was able to briefly look into. So this is challenging, especially in the setting of lichen planus. Now, I do apologize. I know you didn't bring up the setting of lichen planus, but it's kind of my prototypical chronic inflammatory disease that I think about in the mouth. So this is very controversial in nature. You know, especially because lichen planus is an immune-mediated condition at this point. I think that it is probably autoimmune, but I will not call it autoimmune until we actually identify the autoantigen that our immune cells are attacking. So that's just a semantics issue. But technically, yes, chronic inflammation does increase one's risk minimally, but does increase one's risk significantly for oral cancer.
Well, thank you. And Dr. Benjamin Martinez would like to thank you very much, and he says very good presentation.
Thank you very much.
Well, you would like very much to know that Dr. Benjamin Martinez is the president of the Chilean Oral Society of Maxillofacial Pathology.
Muchísimas gracias, señor.
So, well, if we don't have more questions, I think, well, Agustin Marquez says, thanks, Annie, for the cases and your time. Always a pleasure to hear from you. Hope to have you in our country in a close future.
Oh,
also,
lo voy a planear.
Christian Rojas says, thank you very much, Annie. It was a great and very interesting presentation.
Thank you.
Well, we're running out of time and we don't want to keep you any longer. So I would like to thank everyone very much for attending this meeting. You will receive in your mail a link in case you would like to get certifications for your assistants. And of course, on behalf of our faculty of dentistry at Universidad de los Andes, we thank you, Annie, very much for presenting these excellent cases tonight. And we would love to have you in the future.
Thank you very much.
We are very honored to have you, and thank you very much for your time.
Thank you to everyone.
Please, everyone, let's give Annie a warm virtual applause and have a great night, everyone. Thank you very much for coming.
Thank you. Buenas noches a todos.